again, Tim. We're going to talk about myalgia paresthetica, sometimes known as my cell phone's not in my pocket, but I still feel like it's in my pocket syndrome. What do you know about myalgia paresthetica?
What I know is that it's fairly common. It's something that causes numbness, burning, tingling on the outside of the thigh. About a fourth of the cases, it happens bilaterally, and we'll understand why in just a second, because the etiology is oftentimes something that's more systemic. It is more common in males, 3 times more common than females, and it's a lot more common in diabetics, as is any peripheral neuropathy. The problem, like any peripheral neuropathy, is that there's either too much stretch or there's too much compression. So remember, that nerve comes out of the lumbar spine, the upper lumbar area, comes along the medial border of the psoas, and then emerges just below, about 2 finger breadths below the inguinal ligament, and that's where it gets tensioned. So the inguinal ligament cuts into it. It's not really fond of that, and anything that increases that pressure makes it more likely. So 8% of patients who have myalgia paresthetica have gained 15 pounds or more within the past couple of months. So that the increased sugar load at Christmas time pays a dividend. Unfortunately, one you don't like, and that's why it's bilateral a lot of times. Other things that can do that, obviously pregnancy, which is a rapid weight gain, or anything that compresses it, like a tool belt, a police duty belt, somebody who's in surgery lying on their stomach for a long period of time, or compressive garments, things that squish things a little bit more than they should are going to choke that nerve.
Yeah, those peripheral neuropathies are always tough with pregnant patients because pregnant patients have a plethora of issues that really are abnormal for most people, but for a pregnant patient with increased inflammation, it's going to be a little bit more common. These patients, when I talk about that cell phone analogy, is because I had a patient who had that who thought their leg was buzzing when they thought it was their cell phone, and in this case, it was the sensory nerve. So a lateral femorocutaneous nerve is not a motor nerve, just sensory, so that's why we only get those symptoms, the numbness, the tingling, and the burning. And don't be surprised when you do your lower extremity functional examination and neurologic examination, and you go through and you touch that area of the skin, and they don't even know they have this kind of a problem.
Yeah, some hypo or hypersensitivity, really either direction. Our exam of this patient, just like the exam of life, they don't like extension. So they don't like to stand, they don't like to go backwards, and they do like to flex. So when they're sitting, they're usually more comfortable. And our range of motion evaluation will find that as well. The other thing that we're going to see 3/4 of the time is tenderness over the emergence of that nerve. So remember, about 1 or 2 finger breadths medial and inferior to the ASIS, that's peak tenderness. 3/4 of patients are going to say that hurts. Like any other peripheral neuropathy, poking on the carpal tunnel or a thoracic outlet syndrome or pronator syndrome, we're probably going to elicit symptoms with some additional pressure. One of the other things that can be, that is routinely positive, is any type of nerve tension test to that. But when we do the nerve tension test, if you flip onto your stomach, Dr. Steele, we're going to take this patient's leg upward and I'm going to stretch them. This is one version of a nerve tension test. That's a Yeoman test. It's also the femoral nerve stretch test. So the problem here is we're going to potentially elicit symptoms if they're coming from the lumbar spine, from a lumbar radiculopathy at L3, or from lateral femorocutaneous nerve. So we can do that test in the prone position. We can also do it in a sideline position, flipping onto your side, bending the knee to 90 degrees, taking the leg back, and then dropping it down. So this one may not be as provocative for somebody who has a myalgia paresthetica versus a lumbar condition, but the one test I find particularly useful is the pelvic compression test. Remember, sometimes we use this for a sacroiliac joint dysfunction, and it simply involves pushing down on the iliac crest. Well, in this case, what we're doing is we're not putting pressure on that nerve, we're reducing pressure on the nerve, because when we're pushing in on the ilium, we're creating some slack in that inguinal ligament, and that slack takes the pressure off the nerve, so the nerve is happy. So we have a decrease in symptoms, or maybe if there was true numbness, could turn into a paresthesia. So transition from numbness to paresthesia, or a decrease in the discomfort tells us that that's probably somebody who's suffering from myalgia paresthetica.
And keep in mind, this is a nerve symptom, so it's not going to happen right off the bat. It might take a little bit of time when you release that compression. Also, when you have a patient down like that, increasing the amount of hip flexion and knee flexion will help out significantly in taking a little bit of pressure off that area. So one of the great treatments for myalgia paresthetica is going to be nerve mobilization for the lateral femorocutaneous nerve. The way that I do that in my practice, and also I can easily transition my patients at home, is going to be through a prone nerve flossing and nerve tensioning exercise. So the nerve floss is going to look a lot like this. We can tension that nerve going through some knee flexion. As I go further and further knee flexion, I can increase tension on the lateral femorocutaneous nerve. As I go through head extension, I can take away tension to that nerve. Head flexion is going to increase tension in the nerve. So the nerve floss is going to be head up and foot up at the same time. I can bring the head up and the foot up, slowly going until I feel some symptoms or some pulling in the anterior lateral part of my thigh, and head up and foot up. I would do this for the first couple days, let things calm down. As you start to calm symptoms down, you can go through a nerve tensioner. A nerve tensioner is going to be exacerbated with head down and foot up, so the opposite direction, and vice versa. So that's a great way to help your patients get out of pain quickly with nerve mobilization. The other things you can work on is weight loss, clothing changes like a tight belt, like a duty belt for a policeman, or even like a carpenter. I would also consider shoe wear. Shoe wear is a big one with lateral femorocutaneous nerve issues, mostly because of heels, like Dr. Berlesman wears every once in a while. But if you think about it, what heels are going to do is to bring your body forward. They're going to have to bring their body back, and they're going to do it through some lower back extension, exacerbating these kinds of issues.
And probably the number one thing is, since this condition is so commonly related to weight gain, if at all possible, talk that patient into getting rid of a couple of pounds. I found the single best treatment is for them to lose that 15 pounds they just put on at the holiday season. So the good news is, in CareOpe, we have the new nerve flosses, the new nerve tensioning techniques. We've got some standing versions, kneeling versions. We've got a couple of different things that your patients can use and implement to help improve those symptoms much more quickly. We hope that this helps you understand the condition to improve your outcomes. We're proud to be part of your network, and we look forward to connecting again in the future. Thanks for watching. Check out the website for details.